Good afternoon, everyone. I'm Edward Halperin, the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. And welcome to webinar number 7 on COVID-19. It's hard to believe, but you heard it right. Webinar number 7. We've been at these programs since the beginning of the calendar year. And here we are again with our mission of bringing you the most up-to-date information on the pandemic and responding to your suggestions for the talks you wish to hear about the COVID-19 pandemic and its medical and public health management. As we have in previous webinars, we've got some old friends for you and some new friends. Some of our speakers are members of the faculty of New York Medical College and the Touro College and University System who you've met before. And some of our speakers are new, and we hope that you will find the variety and breadth of the topics interesting and informative. But to anticipate the most commonly asked question, how do I get my CME credit? Here's the information. To get your CME credit, for those of you desiring it, text the code 21, capital A, capital N, capital E, capital S, to 828-295-1144, or go to www.eeds.com, click the sign-in button and enter that same code. In either case, you'll start getting instructions as to how to fill out your satisfaction questionnaire with the webinar and how to get your CME credit. Might I suggest you want to take your cell phone and take a picture of the screen, or take a screenshot, or write this information down, so you can be sure to get your CME credit. The website and the text message system will work until 1 o'clock on Monday, November 2nd, before it shuts down, but it's best to do it now while you think of it. We're going to begin our program, as we have with many of our webinars, with welcoming remarks from the president of the Touro College and University System, Dr. Alan Kadish, and after Dr. Kadish, we'll move directly into our series of presentations. Now, remember, everyone, if you have questions for any of our speakers, go to the question and answer spot on your webinar screen, type in your question. We'll be monitoring those questions throughout the webinar, and we will answer as many of them as possible during the question and answer period at the end of all of the talk. So don't hesitate to type in your question on the Q&A box, and we will respond to them after the formal presentations. Thanks for joining us this afternoon. And now let's hear from Dr. Alan Kadish.
Welcome to the 7th Center for Disaster Medicine at New York Medical College and Touro College and University System webinar on the COVID-19 pandemic. I'm Dr. Alan Kadish, president of Touro and president of New York Medical College. I wish I could say that it's great to see all of you back here again, but I'm really hoping that we get to a point where we don't have to keep doing this because the COVID pandemic is under control. We did our first webinar on January 31st when we recognized that COVID could be a real problem, and we've learned a lot since then. But as you can see, from the daily surge in viral cases, we haven't learned enough, and there's still a lot to know. What organs are involved and damaged by COVID, and how is that manifested? What testing strategy is best? Which tests should we use? And can testing and contact tracing really help get the pandemic under control? What antiviral therapies are effective and when should they be used? Will plasma and antibody therapy make a big difference in the course of the disease? What other adjunctive therapies, such as steroids, can be helpful? And in most timely, will vaccines work and when will they be available? For all these questions and many more, we've learned a lot, but we still don't have final answers. And today, the experts from New York Medical College and Touro will try to help provide important information about each of these areas. Most crucially, we're reaching a point where we'll have a good idea relatively soon about whether the first wave of vaccines will be safe and effective. Some have placed very high hopes on vaccines controlling the pandemic, perhaps as early as the beginning of next year. Others believe that continued development of therapeutics will be important. We won't have any perfect answers for you today, but we'll try to do our best to tell you what we know, what you need to know, and what to expect from the future. It is good to see you again, and I do hope we don't have to keep doing this. Welcome, and we look forward to having you join us.
Good afternoon. I'm Marisa Montecalvo, and I'm going to be speaking to you about treatment of COVID-19. I have no conflicts of interest to disclose. I want to start with this slide that we projected on January 31st at the first Touro Symposium, looking at the progression of pneumonia in an early patient with COVID-19. So here you can see illness at day 5 with an early pneumonia, day 8 more progressed, and day 11 with severe pneumonia, acute respiratory distress syndrome. And I show you this because as you look at treatment trials, it's important to look at where in the course of symptoms a drug was started. And you'll see that for many of the trials, day 8 to 9, which is the point of hospitalization in most studies, or of severe shortness of breath, that is the point at which many trials have started treatment. As we look at treatment efficacy, there are various types of studies. When we're dealing with a new pathogen in ID circles, we always pull something off the shelf that we've had previously and offer it as compassionate use. And that will give you some idea of tolerability. Moving on to open label randomized trials where you can compare a treatment versus standard care, but that has the problem that you cannot control for confounding issues. And of course, going on to the gold standard of a double-blind placebo-controlled trial, which limits confounding issues. But in any trial, it's important to always know what the primary endpoint was in the design of the trial, and did they meet that endpoint? So as we look at places, at targets where treatment could work against the SARS coronavirus 2, at the point of the spike protein adhering to the ACE receptor in the lung, this was a point where it looked like hydroxychloroquine could be beneficial. But in clinical trials, it did not prove to have efficacy. Remdesivir, an antiviral that works against RNA viruses and had been tried against Ebola, inhibits RNA polymerase. So it prevents more copies of the SARS coronavirus 2 RNA from being made. And that can be very useful. And in fact, there have been several studies with remdesivir that I'm going to review now. So beginning with compassionate use, where they looked at severely ill patients with pneumonia, 68% of patients improved. The next study was in China, where they compared remdesivir to placebo, but this study could not be completed. They could not fully enroll because the outbreak was brought under control. A very large double-blind placebo-controlled study was performed in the United States with over 1,000 patients and hospitalized patients receiving oxygen. And here the median time to recovery was 4 days shorter for those receiving remdesivir. And then in a subsequent study, they also compared 5 versus 10 days of remdesivir, but did not show a difference. So the study, the double-blind placebo-controlled study, led to the emergency use authorization of remdesivir for severely ill patients with COVID-19. And now there has recently been a study in moderately ill patients where, again, it was shown that in clinical status, they did better quicker. And just a week ago, remdesivir was approved by the FDA for hospitalized patients with COVID-19. This is from the study of 1,063 patients, where you look at the rate ratio as to what characteristics did better. And you can see here to the right of the line of 1, the ratio of doing better was in almost all categories, with the exception of those who were very ill, not just that they were receiving mechanical ventilation, but also were quite critically ill receiving ECMO. All other groups did better on remdesivir. This is a picture of a lung alveolus schematic where we can try to look at the different stages of illness in COVID-19. So the early stage is viral entry and replication, causing infection in the lung, leading to pneumonia. But the more severe stage is where your body is causing damage by the immune reaction to the virus that becomes uncontrolled. And this is the area where steroids like dexamethasone could be beneficial, and other immune modulators like IL-6 inhibitors. So dexamethasone has been looked at in a very large study in the United Kingdom with over 6,000 patients. These were all severely ill patients that were hospitalized, 60% of which were on oxygen at the point of randomization. The endpoint was 28-day mortality. Patients received 6 milligrams of dexamethasone for up to 10 days. And the mortality was significantly less, 17% less in those receiving dexamethasone. There have been several other studies looking at steroid use in patients who are severely ill with COVID-19, and they were evaluated together in a meta-analysis by the World Health Organization. And again, 28-day mortality was significantly less. This is, again, a figure of rate ratio. Here we're looking at mortality versus with dexamethasone versus usual care. So you're looking to be less than 1 to show a reduction in mortality. And you can see that that occurred for all groups except for those who received no oxygen at all. So the role of dexamethasone is really for those requiring oxygen, which due to COVID-19 illness. The Infectious Diseases Society of America has clinical guidelines where they evaluate the data on treatments, and these are the treatments that have been evaluated thus far by the society. Dexamethasone is recommended for critically ill and those with severe disease, whereas remdesivir for patients requiring supplemental oxygen, and 5 days of remdesivir. They have recommended against the use of hydroxychloroquine with or without azithromycin. And due to a study of this IL-6 inhibitor, which did not show benefit, they have recommended against its use, and the others in clinical trials. This, of course, is one of the most famous patients who's had COVID-19 illness. And President Trump's oxygen dropped below 94% on October 2nd, leading to the use of remdesivir. He also received a polyclonal antibody, which is a manufactured antibody similar to the concept of using convalescent plasma for a patient with this infection. That is still in clinical trial, and he received zinc, vitamin D, melatonin, and famotidine, along with low-dose aspirin, which I believe he was already on. He finished 5 days of remdesivir, was discharged on remdesivir day 4, and received dexamethasone on October 3rd when his O2 sat again dropped after the use of 1 day of remdesivir. So here we are almost a year into this pandemic. Are there really any proven therapies? And I think the answer to that is yes. Dexamethasone has been shown to reduce mortality in those with severe disease and is recommended for patients requiring oxygen. And remdesivir has been shown to demonstrate clinical improvement for patients on supplemental oxygen and those requiring mechanical ventilation. It has become clear also that some therapies do not work. What I think is most impressive is that there's really been unprecedented collaboration among investigators performing these clinical trials, and there are a vast number of clinical trials enrolling in progress, antivirals, immune modulators, neutralizing antibodies, adjuvants, and of course the whole literature on the critical care management of these patients. And I'd like to conclude with sharing with you the title of a day that was devoted to COVID-19 by the Infectious Disease Society of America last week during its annual meetings. And the title was Chasing the Sun. And I think that title really speaks to the collaboration and effort that is going on in the study of COVID-19. These are my references, and I would just point out to you that in particular, the last two, the guidelines issued by both the Infectious Disease Society of America as well as the NIH can be very helpful resources. Thank you very much.
Good afternoon. This is your host again, Dr. Edward Halperin. Let me remind you that if you have a question for any of our panelists, go ahead and type your questions in the Q&A function on your webinar screen. We'll be monitoring the questions throughout the program, and we will answer as many of the questions as possible during the question and answer period at the end of the formal presentations. Don't hesitate to type your questions in on the Q&A function. For those of you who didn't get the information the first time I described it, for your continuing medical education credit, text the code 21, capital A, capital N, capital E, capital S to 828-295-1144, or go to our website, www.eeds.com, click the sign-in button, enter the same code, and in either case, you'll get instructions as to how to fill out your satisfaction questionnaire with today's webinar and how to get your free CME credit. And now back to our program.
Good afternoon. My name is Dr. Karen Murray, and I'm the Associate Dean of Admissions for the School of Medicine here at New York Medical College. I'm also an assistant professor in the Department of OBGYN here at New York Medical College. Today, we're going to be looking at obstetrical care during the COVID-19 pandemic. We're going to be looking at the recommendations and key principles as given by the Society of Maternal Fetal Medicine, as well as the American College of OBGYN. New York State took a look at their data for routine screening for the months of March, April, and May, and noted a decline in the screening for pap smears, mammograms, and colonoscopies. We're in the month of October, and October is Breast Cancer Awareness Month. Let me take this time to encourage everyone to have a mammogram done at your earliest convenience as soon as it's safely possible. Mammograms are the only way to screen for breast cancer. What does COVID-19 mean for routine healthcare visits to your GYN? Well, you may see many changes with your regular checkup. Your appointment may be delayed, or you may have a telemedicine appointment. What are some of the things that they look at when they decide which appointment you'll have? They look at your urgent symptoms, how much the virus is spreading in your community, your access to the internet and a computer or a phone, as well as your healthcare team resources. Urgent visits are those when you have a fever that's unrelated to COVID, if you have a vaginal infection, symptoms of an ectopic pregnancy, problems with recovery after a recent surgery or a procedure, as well as severe vaginal bleeding. Birth control visits can be done by telemedicine. You do not need a physical exam or STI tested to get birth control. However, if you're looking for a long-acting reversible contraception or sterilization, this will require an office visit. Your gynecologist may suggest a user control method until you can come into the office. Telemedicine is done either over the phone or by a video call. A birth control prescription, including emergency contraception, can be done with a telemedicine visit. You can also talk about menopausal symptoms, mental health, whether or not you're being abused at home, and discuss options if you find out you're pregnant or think you may be pregnant. You could also have routine check-ins for surgery as well as other procedures. Pregnancy and COVID is still an ongoing phenomenon for which researchers are still learning how COVID will affect pregnant women. We do know that most women who get COVID-19 during pregnancy do quite well with minimal complications. Some pregnant women with comorbidities may require an admission to the ICU or ventilator support. Black and Hispanic women have been noted to have increased rates of COVID-19 infection. This is due to the fact that Black and Hispanic women face social, health, and economic inequities that put them at a greater risk of illness. In-person visits will be spaced around labs and ultrasounds. Take steps to prevent exposure to COVID-19 during pregnancy. The timing of delivery does not need to be changed. ACOG believes that the safest place for you to give birth is a hospital or hospital-based birth center. You and your support person will be tested for COVID-19. Any visitors with respiratory symptoms or fever will not be allowed into the facility. They may also limit the number of visitors to help prevent the spread of the virus. If you have COVID-19 and you need to see your gynecologist, call ahead. Call ahead because you may have to reschedule your visit to avoid spreading the virus. Your gynecologist, if you have an urgent visit, may choose to put you at the end of the day or put you in a separate area from other patients. When you go for this appointment, wear a mask. COVID-19 affects fetuses is unknown. Studies from previous SARS viruses have shown that there's an increase in preterm birth and stillbirth for women. However, the data is being extrapolated to COVID-19 as the research is still ongoing. Keep in mind that your newborn can get the virus if they are exposed. Can I travel if I'm pregnant? In most cases, pregnant women can travel safely up until their due date. If you're planning a trip, talk to your healthcare professional. See whether or not this is essential travel or it can be avoided. If it is essential, talk to them and come up with a plan to help to minimize your risk. Always check with the CDC for travel recommendations. The other place you can check is your local and state health department for the travel restrictions in your area. If you're pregnant and diagnosed with COVID, stay home. Stay home unless you're going out to get medical care. Avoid public transportation. Speak with your healthcare team over the phone before you go into the office. Get medical care right away if your symptoms worsen. Separate yourself from others in your home, as well as wear a mask when you're around other folks or you're going in for your medical appointments. If you're positive and going in to give birth, you should wear a mask. Now, we know it may be difficult to keep a mask on at all times while you're pushing, so your healthcare team will be in full PPE as shown here. Rooming in together may help you bond with your baby and help you start breastfeeding if you desire. Reports show that whether your baby rooms in with you or stays in a separate room, it does not change the spread of infection. However, if you're severely ill, your baby may be separated from you to keep your baby safe. ACOG believes that the benefits of breastfeeding does outweigh the minimal risk of transmission. Studies show that it is safe to feed breast milk to your baby when you have COVID-19. However, make sure you're wearing a mask and you've washed your hands. Do not, and I repeat, do not put a mask or cover your baby's face. Wash your hands before touching your baby. Wash your hands before touching any kind of breast pumps or bottle parts. And if possible, and you have someone who's healthy to help you take care of your newborn, have them bottle feed that baby the breast milk. The risk of dying from COVID-19 remains the same for both pregnant and non-pregnant women. The CDC recommends that if you're pregnant, you should take extra precautions to keep yourself healthy and reduce the risk of getting COVID-19. What should I do if I think I have COVID-19? If you think you've been exposed to the coronavirus and have a fever or cough, call your healthcare professional for advice. Learn the emergency warning systems, and if they're present, call 911 or go to the hospital. Those signs are difficulty breathing, a pain in the chest, sudden confusion, the inability to respond to others, or having blue lips or face. If you do go to the hospital, try to call ahead and let them know you're coming so they can prepare for your arrival. Lastly, if you're home and feeling that you're being abused and you're trying to figure out what can you do, there's a 24-hour toll-free National Domestic Violence Hotline number listed here. Or you can text LOVE-IS to 22522. Thank you.
Good afternoon. I'm Dr. Janet Piscitelli, and I am the Director of Pathology and Laboratory Services for the Westchester Medical Center Health Network. I have spoken before to this group regarding testing modalities, and confusion regarding testing is the only constant in this pandemic. Thoughts around testing for diagnosis, screening, exposure, and surveillance are frequently changing. My disclaimer is the same. What I talk about here today may change in the near future, possibly even tomorrow. I do not have any disclosures. Whether it is a medical health center, nursing home, educational institution, employer, or sports franchise, there are certain elements to consider when instituting a testing program. This includes which type of sample and who will be doing the collecting, whether the testing is going to be performed immediately at the point of care, or if the sample is preserved and transported to a testing facility. Finally, the method of testing needs to be determined, whether it will be a traditional real-time reverse transcriptase PCR, a transcription-mediated amplification, or a more rapid loop-mediated isothermal amplification, also known as LAMP. Also, rapid antigen testing has become much more widely available, but there are some concerns regarding the sensitivity of this type of testing. For any program, the number one consideration is the available resources. Testing programs are not only costly, but there is a shortage of labor for the collection and testing, and self-collection is an attractive alternative. There continues to be supply chain issues, not only with the tests themselves, but in the swabs for collection, plastics for pipetting, reagents, and preservatives used to stabilize the nucleic acid. In response to these shortages, protocols have been developed which utilize saliva and pooling. Pooling is testing multiple specimens at once, and if the pool is positive, then the specimens are tested individually. Pooling has been shown to decrease sensitivity. However, in a low prevalence, low risk population, it conserves reagents, decreases costs, and provides results quicker to those people who are negative. Factors that determine these components are the population and the purpose behind testing. Is testing to determine a diagnosis, a screening test for infectivity, a screening test to prevent spread, for example, in a nursing home, or is it to determine prevalence in a population? The reason for testing, the prevalence of the virus in the community being tested, and the consequences and risk to the population are all considerations in deciding the structure of a testing program. There has been much discussion about the best sample to use when obtaining a specimen for COVID testing. The CDC recommends collecting and testing an upper respiratory specimen for diagnosis. The nasopharyngeal or NP swab in viral transport media is the gold standard with the highest sensitivity of all specimen types. These must be collected by a trained healthcare professional where a swab is inserted into the nostril parallel to the palate and deep enough to swab the nasopharynx. Collecting this sample is a bit uncomfortable to the individual, and some people have claimed it feels like a brain biopsy. It also can place the healthcare professional collecting the sample at increased risk for exposure. A mid-turbinate and anterior nares collections have been shown to be somewhat comparable to the NP, with less discomfort and can be self-collection guided by the healthcare professional, either on-site or at the home. Saliva is less costly, does not require a preservative, and uses less consumables. However, the efficacy, accuracy, and appropriate use remains controversial. It can be difficult to collect saliva samples in the elderly or in the infirmed, and the results can be variable depending on the timing to meals and gum chewing. The testing of untreated wastewater has been used as a method for early detection with other viruses such as polio. It may be useful in a dormitory setting as a leading indicator of a potential cluster outbreak, but then individual testing would be necessary. As I stated previously, depending on the reason to test lends itself to the type of testing. Patients who present to a healthcare provider with symptoms usually have a high viral load. Because of this, any of the FDA emergency use authorized tests for diagnosis are acceptable, including rapid tests performed at the point of care. The caveat here is that the RT-PCR performed in a CLIA certified laboratory remains the gold standard. If someone has symptoms and tests negative with either a LAMP PCR or antigen test, it is recommended that that person be retested using RT-PCR. There was some controversy on using testing to determine the infectivity of a person and if they can discontinue quarantine. The cycle time for PCR testing, which is inversely proportional to the viral load, has been suggested as an indicator of infectivity. This remains unclear, and evidence supports discontinuing isolation using only symptom-based strategy. The only group in which a testing-based strategy should be considered is in the severely immunocompromised individuals. However, this is based on limited information at this time. Another reason to test for diagnosis is in those individuals who have had an exposure by being in close contact with somebody with a documented SARS-CoV-2 infection. All of the viral testing is acceptable, and it is recommended that the person self-quarantine pending the result. Additionally, the CDC recommends continuing to self-isolate even if the result is negative. For those people who cannot isolate, appropriate cautions should be taken, including masks, social distancing, etc. A third group of individuals who may require testing are those that belong to a community or are in a situation in which there is increased risk for spread of the virus. This includes dormitories, workplace environments, hospitals, and athletic teams. This is to protect the community and contain an outbreak. This testing is just one component of a comprehensive strategy and should be used with a program that promotes behaviors that reduce spread and has a plan for isolation and contact tracing if someone tests positive. In this case, if the prevalence is low or if pool testing is in place, all positives should be confirmed using RT-PCR while the person remains quarantined. Additionally, depending on the risk of morbidity to the population, less sensitive assays may be acceptable. For example, if you have a college environment and we know this virus is less severe in that population, frequent random testing of a percentage of the student body and staff should be suitable to detect a potential outbreak. However, in testing asymptomatic trauma patients in an ER, it is vital that the gold standard be used because this would mitigate the risk of cohorting an asymptomatic positive patient with a non-COVID patient. We are all aware of the risk to nursing home patients. The CDC recommends health departments develop and implement a strategy for prioritizing testing among nursing home residents and healthcare personnel in these facilities with serial testing. Similar to the institutes of higher education, there should be a plan to respond to results prior to initiating testing. Regulatory agencies have mandated that any testing on individuals, whether it be for diagnosis or screening, must be performed under the umbrella of a CLIA certified laboratory. Surveillance testing is intended to monitor community or population outbreak of disease and to characterize the incidence of and prevalence of the virus. Surveillance testing is performed on de-identified specimens and is not linked to individuals. By having systemic testing activities, these results give valuable information to the public health groups. It is independent of the bias from people seeking healthcare or who are symptomatic, therefore giving a truer picture of what is happening in the community. It is useful to assess the effectiveness of mitigation strategies and does not require testing at a CLIA certified laboratory. Although surveillance testing is primarily performed by randomly testing people in a community, testing of wastewater can be an adjunct, especially in dormitories or in prisons. As positivity increases, then the entire dorm or prison would require screening tests. It's not very useful in the general community because it would be difficult to pinpoint the exact location of the cluster, nor would it be a true picture as some areas continue to have septic systems which would not be tested. When deciding the appropriate sample type, method, and program for COVID testing, the initial question that must be answered is what is the purpose for testing? Each situation, whether it be testing of symptomatic, exposed, or to identify potential asymptomatic contagious people, is variable, and there is no one right solution. The testing algorithm depends on the situation, prevalence, and risk of the testing population for exposure. I hope this helps with some of the confusion. Thank you very much for your time.
Hello again. This is your host, Dr. Edward Halperin. For those of you wishing to obtain CME credit, text the code 21 and then all capital letters ANES, 21 ANES. Text that code to 828-295-1144 or go to www.eeds.com, click on the sign in button and enter the same code. In both cases, you'll start getting instructions as to how to get your CME credit and how to fill out your questionnaire regarding satisfaction with today's webinar. And now let's return to our presentations.
Good afternoon. My name is Salomon Amar. I'm the Vice President for Research at New York Medical College and a Professor of Pharmacology and Microbiology and Immunology at New York Medical College, as well as Professor of Dental Medicine and a Provost of Biomedical Research and Chief Biomedical Research Officer at Touro College and University System. What I'd like to speak to you about today is what probably has been in the mind of many people is what is the importance of a naturally attenuated or potentially attenuated SARS-CoV-2 in the fight of COVID-19. So as you saw in the announcement, the questions were, we are almost a year into the pandemic. Do viruses in general change during the course of that pandemic? Do they mutate? Do they become more aggressive? How do they attenuate, and what is the impact on this current pandemic? It would be an understatement to say that SARS-CoV-19, yes, is a pandemic that is wreaking havoc throughout the world and is now a global health emergency. Although currently available data on the mortality of SARS-CoV-2 caused pandemic should be interpreted with caution, seems that the case fatality rate tail off even in location with less effective containment measures. And that the question that comes to us is why some individuals become sick and others do not. Many have pointed already at a variation in risk factors between individuals. However, the variable outcome of COVID-19 infection may, at least in part, be due to differences between the viral subspecies with which individuals are infected. And finally, a more pertinent question that probably evolves from this is how are we going to overcome the current pandemic? So the currently available sequences, genomic sequences of SARS-CoV-2 isolates from across the globe confirm the potential of what we call in genetic, a genetic drift, a change that is occurring in the genome of the virus. Although association between these genetic alteration and the severity of the clinical outcome are sparse, there's a hint in what we call attenuation that comes from an observation recently published in Singapore, where SARS-CoV-2 isolate turned out to have a missing nucleotide, 382 nucleotide deletion. And with that deletion, that translated into reduced virulence. So the sequencing efforts so far probably underestimate the emergence of attenuated SARS-CoV-2 variants. Most of the isolate that we currently have been harvested and analyzed from derived from individuals that were seeking medical care and probably unlikely to have acquired features leading to reduced virulence. Therefore, we do not have asymptomatic strains. Instead, currently existing attenuated SARS-CoV-2 variants should be researched in the large pool of infected individuals that remain asymptomatic. And with the screening that we have in place in many universities, it would be very interesting to harvest asymptomatic samples from individuals that have not expressed any symptomatic clinical symptomatology. So viral variants should be linked to various level of virus and attenuation, or for that matter, aggressiveness or increased virulence. Such finding would have implication, obviously, in diagnostic prognosis, disease support management, and probably also into the policy for the management of the pandemic. We do have the capability of sequencing. This is not a problem, and it's feasible to sequence hundreds of thousands of viral genomes, starting with raw material collected from qPCR. And the testing capacity is expanding, as I just mentioned. When we have screening systems, and particularly Sentinel program being present in many settings, it should extend to samples from asymptomatic individuals, and the sample identification of positively tested individual would basically allow the determination by follow-up of who was and remained asymptomatic. And then the question is, with all viral sequences for symptomatic and asymptomatic, following up clinical outcomes, we would be able to compare the genome of asymptomatic versus symptomatic and define whether the people that did not express symptoms, they did not express symptoms specifically because they had an attenuated virus. The next step would be to score for specific genetic determinant of the virus, in particular deletion, and that can be done with enriched within the pool of isolate that we derive from asymptomatic population, but absent into the symptomatic COVID-19. Finally, the focus of this endeavor should be on those genetic determinants that would correlate with asymptomatic outcome that would be spread at relatively high frequency, and that's what we fear right now. It is important to notice that these potentially attenuated sequences are also potentially found in individuals who otherwise would be at high risk of developing severe symptoms for COVID-19, such as the people greater than 60-year-old individual with comorbidity, diabetes, and high blood pressure that are considered to be risk factors. These individuals could then be approached to be tested for having undergone potential seroconversion and for consistent and prolonged asymptomatic status. Then in this case, it would be easy, at least for some time, to determine whether these individuals are protected from reinfection with the confidence assessment at least comparable to what the current standard of efficacy phase 3 clinical trials concerning a typical designer vaccine. And in other words, the pandemic itself already may have inadvertently performed a natural clinical trial, which for regular vaccine takes forever to, it takes a time-consuming step. So how do we capture this type of attenuation? As you can see, in November, the virus could have been very, very virulent. And as it moves from a host to another one, the replication within different hosts could have generated defective viruses, and as a result, we would obtain, at the end of the day, a virus that is significantly attenuated. Only a whole genome sequencing that we have available between sequencing from November 2019 and with virus samples of February, for example, compared to October, the one that we have currently, and especially in asymptomatic, is able to answer this question. One has to understand that there are a current trend that advocates lack of genetic diversity in SARS-CoV-19. So a few papers have been published recently, and with concern associated whether or not the vaccine candidate would likely match all currently circulating. And in fact, a limited diversity seen in SARS-CoV-2 should not preclude a single vaccine, advocating for a lack of diversity in the strains that we have so far. Another paper evaluated the emergence of genomic diversity. There were some diversity, but the vast majority of the mutation observed in SARS-CoV-2 circulating in human were likely to be neutral. As I said at the beginning, viral factors and genetic diversity may not be the only answer. It would be very, very premature and very naive to believe that it will be only a attenuation that is behind the decreased rate of hospitalization and mortality from COVID-19. It's probably a constellation of factors, which are host factors as well as environmental factors. I need to mention that age, comorbidity, and risk factor, large cohort of high-risk people have already been exposed and developed the infection, especially in the nursing home resident. In the environmental factor, a decreased exposure amount of virus is being reduced because people are practicing social distancing and the facial covering. Genetic predisposition, and we have the blood groups that is advocated currently. Immune mediated as a genetic predisposition that I spent some time to explain to you in one second. In the environmental factor, I'd like to mention household contact versus other in the duration of exposure. Most of the contact that we have is in the household because people are confined into the same environment. Herd immunity in pocket of high risk socioeconomic as host factor, but in environmental factor, facial covering and increased adherence to practicing social distancing is also responsible for the decreased rate in hospitalization. And finally, the role of masking with the decrease of viral transmission from symptomatic or asymptomatic infected patient. What do we mean by host factors? Age, as you probably know, comorbid condition, obesity, cardiovascular, chronic disease, dementia. And recently, genetic predisposition, autoantibody, especially to type 1 interferon patient with life-threatening COVID-19. Interferon are the major element that we have been circulating in serum that are aimed at the virus. And when antibodies are destructing this kind of viral response, you have life-threatening COVID-19, and we observed autoantibody against this, especially interferon omega, the 13 type of interferon gamma that neutralize the ability to corresponding type 1 interferon to block the virus in vitro. Inborn error on type 1 immunity in patients with life-threatening, specifically rare variant predicted the loss of function in 13 elements associated with immunity against COVID-19 were detected, and that was relative to 534 subjects with asymptomatic or benign infection. And the last one is genetic variability in the expression of SARS-CoV-2 host cell entry, especially in two markers, the converting enzyme and other markers, specifically among individuals and between population, indicating a genetic predisposition for lower expression level of this both viral entry, this converting enzyme, and this factor, proline and serine specific protein are key viral entry genes in specifically in African population. And in conclusion, I'd like to bring to you that as on a whole, the current global crisis is of a magnitude such as that it's feasible to identify currently existing attenuated SARS-CoV-2 variants and to assess the prevalence. The effort would be instrumental not only to better understand the evolution of SARS-CoV-2, but as it spread among individuals, but also to predict the dynamic of the current and possibly future pandemic. The knowledge of attenuation might also have relevance in developing safer and more effective anti-COVID-19 vaccine. Live attenuated anti-SARS-CoV-2 vaccine would entail some unknown degree of risk and may cause unpredictable outcome, for instance, due to recombination event, in particular, if the non-attenuated virus would remain widespread. Determination of naturally circulating attenuating COVID-19 variant is definitely an urgent matter, specifically for the vaccine design against this pandemic and specifically against COVID-19. A vaccine would offer a significant relief, but one has to be cautious. Although vaccine developers have warned that design, testing, and production of vaccine may take a year, if not longer, we can say that vaccines are based on a handful design. But the earliest vaccine that we had were based on the live mutated and may naturally attenuate over time. We consider that this naturally attenuation could occur in COVID-19. What makes the pandemic, this current pandemic, unique is thanks to the state-of-the-art nucleic acid sequencing technology, we can follow in detail how COVID-19 is evolving while it spreads. We argue that knowledge of naturally emerging attenuated COVID-19 variants across the globe should be of key interest in our fight against the pandemic. I thank you very much for your attention.
Good afternoon again. This is Dr. Edward Halperin to talk with you about the topic very public illnesses, presidential and celebrity infirmity. I have no conflicts of interest to disclose. The President of the United States is diagnosed with COVID-19. He walks across the White House lawn to a Marine helicopter to take him to check into Walter Reed National Medical Center. The press alleges a cover-up. The President's physicians are closely questioned at press conferences. How might we understand this episode in American history in the context of previous presidential and celebrity illnesses? Well, with presidential illnesses, sometimes we're told the truth, sometimes we're not, and mostly in our history, we're not. The protracted gastrointestinal illnesses that led to the death during the first half of the 19th century of Presidents William Henry Harrison and Zachary Taylor were reported to the American people by the telegraph. The shooting on a Friday night and the death early Saturday morning of Abraham Lincoln in 1865 was also sent out to the American people by telegraph. In 1881, President James A. Garfield, while walking through a train station in Washington, D.C., was shot by an assassin. The president lingered for 2.5 months, dying a horrific death from unsanitary techniques used by his physicians in probing the wound. The president's wife, Lucretia Garfield, asked for homeopathic physicians who would have taken a less aggressive approach. Perhaps if anyone had listened to the First Lady, Garfield might have lived. Instead, he died of sepsis, and the American people were notified twice a day throughout the protracted illness of the president's condition by his team of physicians. In contrast, in the 1890s, when President Grover Cleveland felt a mass in his palate, he told the press corps that he was going for a 4-day fishing trip. While on the fishing trip aboard a yacht, no fishing was done. Instead, a 6-member team of physicians and dentists resected the palate of the president, who had a squamous cell carcinoma of the palate, and fitted him with a prosthesis. The American people were told nothing of the illness, and when one reporter tried to break the story, it was vociferously denied. Cleveland did not want to roil the stock market. There was no hiding from the American people the assassination and death of President William McKinley at the turn of the last century, but the American people were kept largely in the dark when, in 1919, President Woodrow Wilson suffered a debilitating stroke and served out the last part of his presidential term in seclusion. Nothing was said about the cardiovascular disease of the Republican candidate for president in 1920, who succeeded Wilson, Warren G. Harding. Harding won the election and died in office of cardiovascular disease. In the 20th century, we came upon a new world of celebrity journalism, and the archetype of reporting celebrity illness was that of the iron horse of the Yankees, the captain of the Yankees, Lou Gehrig. After 13 years of never missing a game, he pulls himself from the lineup because he's feeling weak. He goes to the Mayo Clinic, is diagnosed with amyotrophic lateral sclerosis. On the 4th of July, in the middle of a doubleheader, he gives "I'm the luckiest man on the face of the earth" speech. He dies not long thereafter, and the American people know about it. But the press goes gently on the Gehrig. Great respect is held for Eleanor Gehrig, Lou Gehrig's wife, and the Gehrigs are given relative privacy. There is no hiding from the American people, however, a few years later, when a drawn, gaunt Babe Ruth, dying of carcinoma of the maxillary sinus, goes before the fans at Yankee Stadium. Ruth is treated with a combination of radiation and chemotherapy. He is reported to be a complete responder, but goes on to die shortly thereafter. The American people knew about Franklin D. Roosevelt's polio and that the president couldn't walk, but they were not told about the extent of his hypertension and cardiovascular disease. Leaders of the Democratic Party are worried that Vice President Henry Wallace is too far to the left, and if Roosevelt dies in office, Wallace will succeed to the presidency. They try to find a more moderate candidate and remove Wallace from the ticket for re-election in 1944. They are concerned, for example, that at Yalta, Roosevelt might have his cognition impaired by cardiovascular disease and be making bad choices in negotiations with Churchill and Stalin. On the ticket for 1944, they put Missouri Senator Harry S. Truman, and when Roosevelt dies in 1945 of a stroke, Truman succeeds to the presidency. In the 1950s, the American people are concerned when "I like Ike," President Eisenhower suffers a heart attack. But in the archetype of how to reassure the American people, the president's cardiologist, Paul Dudley White, seen here wearing the fedora, riding a bicycle behind Mayor Daley of Chicago, Paul Dudley White, the father of preventive cardiology, reassures the American people that the president is going to be okay and that you can survive a heart attack. The American people do learn about the slow death of Secretary of State John Foster Dulles during the Eisenhower administration. We have had a difficult time as a group of citizens learning about mental illness or alcoholism among politicians and celebrities and debating whether these are diseases or moral failings. For example, the protracted bouts of alcoholism and mental illness of Hollywood star Rita Hayworth upset and perplexed the American people over many years. HIV rewrote the playbook for celebrity illness. Senator Joseph McCarthy's lawyer, celebrity lawyer, lawyer to the Trump family, Roy Cohen, denied he was gay and denied he was dying of AIDS up until the day of his death. Movie star Rock Hudson was a bit more forthcoming about his sexuality as he was dying of HIV. When it comes to celebrity illness, we're all created equal, except where we're not. Thus, the argument about whether or not Mickey Mantle, baseball star, was pushed forward in the queue for a liver transplant because he was Mickey Mantle. Let's now think about the influence of public illness on private behavior. Some cancer control specialists have asserted that the fact that Ronald Reagan didn't want to talk about his colon cancer, that Nancy Reagan forbade the use of the word cancer in press releases, decreased screening for colon cancer. But First Lady Betty Ford's forthcoming discussion of her breast cancer may have increased breast cancer screening, which then took a detriment when First Lady Nancy Reagan didn't want to talk about her breast cancer and had a mastectomy rather than breast conservation with lumpectomy and radiation. The question of presidential and celebrity illness raises questions regarding fitness for office. The American people were not told much about the fact that John F. Kennedy had Addison's disease and had had multiple hospitalizations in the 1950s. Lyndon Johnson had suffered a devastating heart attack in the 1950s, but this was not discussed when he ran for a full term in 1964. Hubert Humphrey, through retrospective diagnostic techniques, might have known with modern technology that he had bladder carcinoma when he ran for president in 1968. If he had known, should he have run? Would he have run? Very little was said about the fact that when John McCain ran for president, he'd already undergone 2 resections for deeply invasive malignant melanomas, and the risk of recurrence was high. Such questions are rarely discussed. In conclusion, serious policy questions are raised by the illnesses of celebrities and government leaders. They include, what are the boundaries of privacy for the public and the press? Do people whose lives have been defined by celebrity and who constantly seek the attention of the press and the public suddenly get to decide that they're no longer subjects for press attention when they're ill? Do American voters have the right to know the health status of those who wish to be elected or appointed to lead them? Do boards of trustees or boards of directors of corporations or universities have the right to know the health status of those under consideration to lead their organizations? We certainly don't allow high-priced baseball players to be traded from one team to another without a physical, but we do that all the time with our leaders. And do political leaders and celebrities get special medical care? Do we send messages to the public about the choices they should make with their health care as a function of the care given to prominent politicians and celebrities and their family members? I hope that this afternoon I've given you a basis to think about some of these questions, and thank you for your attention. Hello, this is your host, Dr. Edward Halperin, and a final repetition of how to get your CME credit. Go to either our website, www.eeds.com, or text to the phone number 828-295-1144. And if you text, enter the activity code 21ANES, or if you go to the website, click on the sign-in button and enter the code. And in both cases, you'll start getting instructions as to how to fill in your satisfaction questionnaire with today's webinar and how to get your CME credit. You might want to take a moment to do a screenshot, write these numbers down, or get your cell phone out and take a picture, because you'll be able to do this up until 1 p.m. on Monday, November 2nd. After that point, the CME website will shut down. Good afternoon, everyone.
Welcome to the question and answer period. We've had a couple of questions about vaccines, and I promised you we'd give you a little bit of a vaccine update. So the questions about vaccines are, first, can we have an update? And we'll do that. And second, given the uncertainty about vaccines, should we adopt the Swedish herd immunity solution to taking care of the COVID-19 pandemic? So we had an extensive discussion of vaccines at the last webinar, and the reason we've only briefly alluded to them today is not much has changed. There are several different types of vaccines that have been tested. The attenuated virus type that Dr. Amar referred to, mRNA vaccines, adenovirus vaccines, and some of them are in relatively late stage clinical trials. But there have been no recent results that have been shown. Just today, there was hope that Pfizer would announce the results of the first interim analysis of their vaccine trial. Unfortunately, based on what we've learned from the CEO, they haven't reached the number of endpoints needed to even take the first look at the data. So the earliest we're going to have data on the Pfizer, Moderna, or AstraZeneca vaccines is sometime in mid to late November. At least that's the best information we have as of now. And of course, we'll have to follow those patients to make sure the vaccines are safe, get them manufactured, and get them distributed. So there is no short-term vaccine fix in the next couple of months. Most public health experts and epidemiologists have suggested that the Swedish approach to herd immunity has been detrimental. Death rates have been high, and in the United States, most analyses suggest that if we tried to adopt a herd immunity strategy, that hundreds of thousands of people would die. And so no one is seriously recommending in the United States that we adopt a herd immunity strategy. We're hopeful about the vaccine trial results, but we just don't know yet. And as Dr. Amar said in his talk, there are some pluses and minuses to the genetic drift that we're seeing in terms of the ability to quickly develop a safe and effective vaccine. I wish we had better news, but as of today, the answer to the first question, what do we know about where vaccines are going, is we're still waiting for good controlled data. The preliminary trials show that people develop antibodies, but whether that will mean that we're protected from the virus, we just don't know yet. There are also a couple of similar questions about therapy for Dr. Montecalvo, and the questions relate to President Trump's treatment. President Trump got a variety of treatments: dexamethasone, remdesivir, and a Regeneron cocktail, and seemed to get better pretty quickly. But as Dr. Halperin mentioned, we don't really know all the details of his disease, and I'm not sure we can tell how the therapy potentially affected him. So the question for Dr. Montecalvo is, if that combination of therapy worked for the president, why don't we give it to everybody?
Thank you. Thank you for the question. So the president received remdesivir because his oxygen had dropped initially, and that's now FDA approved and is advised if your PO2 is less than 94%. He received dexamethasone when his oxygen dropped further. The other which is also recommended. The other medications which he received, which are the polyclonal antibody from Regeneron, zinc, and famotidine. As I said, the low-dose aspirin we believe he was already on. So the polyclonal antibody by Regeneron is very hopeful. The concept is similar to the concept of convalescent plasma, that if you can give neutralizing antibody early on, that will break the cycle of infection. But until there are randomized controlled studies, you can't just give that to everyone. There are many good ideas that don't necessarily pan out in clinical trials. In fact, Eli Lilly just announced that they had concern about their monoclonal antibody that was in development. So I think we have to wait and see. It's very hopeful about the Regeneron product, but until the clinical trial is published, I don't think we know the answer, and it cannot be just given to anyone. The use of zinc comes from anecdotal information that people receiving zinc seem to do better. Again, is it of benefit or not is awaiting trials. And famotidine is something that is being looked at in clinical trials, and the results are not out yet.
Thank you, Dr. Montecalvo. A couple of other questions for you, so just stay with us, please. So the first is, one of our questioners has looked at some of the privately published websites about hydroxychloroquine. And I will add to that question that a physician from Rockland County published his uncontrolled data yesterday, showing that when given early in the disease, hydroxychloroquine, zinc, and azithromycin in his uncontrolled study appeared to result in very good clinical results. In your mind, is the hydroxychloroquine question settled? Or are there still possibilities that when used in other ways, hydroxychloroquine may be effective?
I think it's a bit settled, but there are placebo-controlled trials that we're still awaiting. So I just want to remind everyone that the way hydroxychloroquine received its emergency use authorization was very early, and it was based upon a very small French study that had a lot of confounding issues. Some people got hydroxychloroquine and azithro. Some people only received hydroxychloroquine. It was a very small study. But given the pandemic and the urgency for treatment, it received an emergency use authorization. 2 large studies after that, one out of the New York State Department of Health and the other one led by Dr. Schluger, the work that he did at Columbia, both showed no difference, no reduction in mortality, in his study in mortality or in the requirement for mechanical ventilation. And in the New York State Department of Health, no reduction in mortality with the use of the drug, and importantly, increased side effects, so that people receiving the treatment had more cardiac arrhythmias. So with an emergency use authorization,
it's not just allowing the use of the drug, it also has to be reasonably safe. And given those side effects, the emergency use authorization with those results was removed. There are several hydroxychloroquine trials that were started, and we're waiting to hear all of the results. In terms of prevention of infection, that study has been published, and in households where there has been exposure to SARS coronavirus 2, it did not reduce transmission. So things are, not looking favorable on the large placebo-controlled studies, which is the gold standard. And I think anecdotal information we have to remember that it's anecdotal and it has to stand the test of a placebo-controlled trial.
So thank you very much, Dr. Montecalvo. We may get back to you a little bit later. So here's a question about testing for Dr. Piscitelli. If a family or a group of people want to get together, Dr. Piscitelli, what testing would you recommend? Is there a testing strategy that would make it safe for them to get together, let's say for the Thanksgiving holiday coming up? What would you suggest?
Well, it's still unclear. And if it's a small gathering of less than, let's say, 25 people, and someone wants to consider testing, any of the available tests out there would provide some information. However, none of the tests are FDA authorized in asymptomatic people. The caveat, of course, is that all the participants should not be symptomatic or have a known close exposure to somebody with COVID within the few days prior to testing. And even if you test people, remember, regardless of the test, there is still a chance of transmission, as we saw with the Rose Garden event, in which the whole group were tested, but there were people who were positive. No test is 100% sensitive or specific. So, it's best to employ common sense, and the best program is to quarantine prior to the function.
Thank you very much. Here's a couple of questions for Dr. Murray. The first one is, can COVID-19 present with gastrointestinal symptoms only and then not progress to respiratory symptoms?
Thank you for the question, Dr. Kadish. There has been some patients who've been shown to have only GI symptoms for COVID-19 and not have respiratory symptoms for COVID-19. So, the vast majority of people do have respiratory symptoms, but I think that if you're having GI symptoms and you're not really sure what they are, you should call your clinicians and, either speak to them over the phone on a televisit, or make an appointment to go in and be seen and get tested in lieu of everything else. Thank you.
Thank you, Dr. Murray. We're going to go back to Dr. Montecalvo for a second. There are a couple of practical questions here. One is about going to the hairdresser. The other is restaurants. We know that Dr. Halperin spoke a lot about politicians. We know there was a famous hairdresser visit by one of our politicians. And then also a question about restaurants, indoor dining in restaurants, if the restaurants do follow the guidelines, which currently in New York State are 25% capacity, although a variety of business groups have appealed to the governor for November 1st, going to 50% capacity indoors. So what would you recommend about going to the hairdresser, going to indoor dining in a restaurant as things get colder? Are the current precautions safe enough, or would you advise people to hold off?
Well, going to the hairdresser is something I can certainly relate to. So, I really believe face masks work. This is a virus that is transmitted by droplet transmission. And face masks are really important and they work. And, this is similar to influenza in that way. And I want to remind everyone that in the Southern Hemisphere this year, the rates of influenza were much lower than ever before, probably due to the use of face masks. So, I do think that you can do things as long as you're practicing social distancing and wearing a face mask. The restaurant situation is complicated because you cannot eat with a face mask on. And, you know, I think you really have to think about that carefully. I mean, I certainly don't want to see restaurants go out of business, but I think you really have to think about where are you going to be sitting? How long are you going to have that face mask off? How long are you going to be there? For me personally, I have not chosen to do that at this point because I talk a lot and I would be with my mask off for a prolonged period of time. So, you know, I think it's all about the face mask. You have to be able to wear a face mask and practice social distancing if you want to prevent acquisition of this virus.
So a follow-up question from one of our listeners who apparently heard you speaking about face masks, who wants to know if the addition of a face shield provides additional benefit, and maybe if that's something they should consider in certain circumstances. How you would do that at the hairdresser, I'm not sure, but there may be other places where you could use a face shield in addition to a face mask. Does that make a difference? Is that something we should be doing?
Well, a face shield is to prevent inoculation of mucous membranes and of your eyes, right? So I don't think that you need to routinely use a face shield. We do use face shields when seeing patients of unknown status, just in the event that there could be, you could be seeing someone who could have the SARS coronavirus too. But in routine non-patient care situations, I don't see a role for face masks, and I don't think, and CDC has certainly not advised use of face shields in general, in addition to a face mask.
So one last face mask question, Dr. Montecalvo. Someone, one of our attendees asked a question about, is it reasonable to mass produce N95 face masks with the question of, are those more effective than the commonly available surgical or cloth masks? And is it worth trying to do that to decrease transmission of the virus? Or do you think that the current face masks for routine population are good enough?
So surgical procedure masks and face masks are very good. And there has been quite a bit of work looking at this. The N95 is really recommended for the situation of an aerosol generating procedure in the event that there is some airborne transmission. But for the general public, for the general situation, use of certainly the surgical procedure mask and cloth face masks look very good. And there's been quite a few reviews on that at this point. So in answer to your question, for the general population, no, it doesn't make sense to really be mass producing N95 respirators.
Dr. Halperin, I'm going to actually ask you a couple of questions that just came in. So the first is, I know you've spent a lot of time thinking about this and speaking to students. Why is it you think that there's been some resistance to guidelines regarding face mask wearing, which Dr. Montecalvo just spoke in such detail about?
Thank you for the question. First, I want to continue Dr. Montecalvo's comments about the face mask issue. If you look at photographs of surgeons in the operating room in the 1920s, 1930s, and 1940s, are they wearing paper disposable face masks? No, they're not. They're wearing cloth masks. In fact, there was no effect on infection transmission in the OR by the switch from cloth masks to disposable paper masks. Cloth masks could be laundered and reused, but we went to paper masks when after World War II, we went to the one use and throw it away society. We would not have had as much of a shortage, allegedly, of masks at the start of the pandemic in March, April, and May if people had been as comfortable using cloth masks as we used to be. We, in some sense, brought this shortage upon ourselves by the idea that disposable paper masks were better. If you look at compare an N95 to a cloth mask, cloth masks are about the equivalent of N93s to 87s, depending on which they use. They're very close. This type of mask, which I use, is a cloth mask with impregnated wires in it, which impute a positive charge on airborne particles to increase the rate that they stick to things, and they're a bit better. Now, onto the question of why people aren't following guidelines. Americans have a combination of a belief in their own immortality, their own invincibility, and some notion that individuality overcomes the need of collective responsibility. All of these are to the detriment of controlling a pandemic. Those societies in which people follow scientific directives seem to have controlled the pandemic better than we have. If you look at data from countries such as New Zealand, if you look at the data in Vermont or Washington State, where public health officials took the reins and people were more compliant, we have done better. But we don't seem to do so well because sometimes we're stubborn, sometimes we think it's all about individuality and not about the collective. I would say finally that there seems to be a special case of young people in college settings. We have seen innumerable examples of mass parties and group gatherings of college students. This seems to be part of youthful exuberance and belief in their own immortality, but also a deep-seated need for interacting with their classmates, for being part of the group, for not feeling left out. And therefore, one would think that in higher education in particular, specific efforts need to be made to create safe ways for people to interact without putting themselves at risk for not social distancing and not wearing masks.
Thank you, Dr. Halperin. So a quick follow-up question on masks for Dr. Montecalvo. So if you had a choice between a surgical paper mask and a cloth mask, which would you use? Which would you recommend as being better, since you already indicated that masks are really important and you think they do a very important job of helping control the pandemic?
Outside of a clinical setting, that is outside of seeing patients, I would use either or, whatever I had, as long as I had a good cloth mask that I felt covered well and fit me well. In a patient care setting, I always use a surgical procedure mask, because that is how we assess whether there's the potential for transmission, either from me if I became infected to someone else, or from someone else to me. So that's what I use in any kind of clinical situation.
That's great. So the next question is for Dr. Amar. Thank you very much, Dr. Montecalvo. And the question is, what have we learned about how COVID-19 is really transmitted? Dr. Montecalvo spoke about particle transmission, but can you just tell us if you think there are other ways that COVID-19 may be transmitted? What are the risks and how can we protect against them?
Thank you very much, Dr. Kadish. The way COVID-19 is transmitted remains essentially the same just like Dr. Montecalvo mentioned. When a person coughs, sneezes, or talks, droplets that are produced are tiny particles called aerosol that we see also in aerosolization procedures in medicine and in dentistry. And they do carry the virus into the air from the nose and the mouth, and anyone basically within 6 feet of that person can breathe it into the lung. How do you protect? As Dr. Montecalvo mentioned, the covering of mouth and nose is essential with the mask around others. And remember that the mask is meant to protect others in case you are infected.
Thank you very much, Dr. Amar. The next question I'll handle quickly is, what would you recommend if a healthcare provider, in this case, the questioner says a chiropractor, doesn't wear a mask, but spaces out his patients? Is he at risk for his patients? My short answer is I would see a different healthcare provider. There's no reason for a healthcare provider not to wear a mask. Not wearing a mask increases the risk of transmission. And when you're dealing with a chiropractor or a physical therapist, there's going to be close contact. And even though the virus mostly spreads by the respiratory route, There have been cases reported of contact spread. So you're looking for a healthcare provider who, just as Dr. Montecalvo said, is going to follow appropriate precautions. And there's no reason at all for a healthcare provider not to wear a mask, not to be sure to be very careful about keeping their hands clean or wearing gloves, because there is a risk of transmission. And there's no excuse for not taking those precautions. One last question about physical therapy and both wearing masks in a room with open windows. Are you safe? Is the last question we'll take today. The question that just came in. So, safe is a complicated question in dealing with COVID-19. The question is, in the appropriate setting, should you be willing to take very small risks to get healthcare? Some of the speakers today have talked about how important it is to continue the appropriate screening for breast cancer, for colon cancer, for cervical cancer. I think if in a physical therapy setting, if both the therapist and the patient are wearing masks, and if proper procedures are followed, the risk is very low. It's not zero, but if you need the physical therapy, and I've had some family members who've done that, if you need the physical therapy and the right precautions are taken, I think from what we know now, between masks and hand washing and gloves, it's reasonable to go ahead with it if it's something you need. So I want to thank everybody who's been with us today. Some great talks. We hope at the next webinar to have more progress. Very much appreciate the questions from the audience. Stay healthy, stay safe, follow the guidelines, and let's hope that we get this under control sooner rather than later. We've got to stop meeting like this. Thank you very much.